Hello, everybody, and welcome back to another episode of Hybrid Healing Hour. Today, we are going to be talking about colorectal cancer. And we have a friend and fellow colleague with us today, and it is Blair Muller. Please introduce yourself to our audience today.
Before she does, I'd also like to say I've known Blair a long time. Blair was one of my former students, an excellent student, and I knew she would do great things in life. But I actually knew Blair before she even went to PA school, so very happy to have her on this podcast.
Thank you both for having me. I'm excited to be here. So I've been practicing hematology oncology for a little over 5 years now in the Northeast. And we see a lot of colorectal cancer. So I'm really happy that we're doing a topic about it and raising awareness.
Beautiful. And I always say, this is one of the only cancers in which screening can actually be preventive. It's early detection is key. And now we're seeing it in patients a lot younger. Why don't you go ahead and tell?
Yeah, so about 1 in 10 patients with a new colon cancer diagnosis and 1 in 4 patients with a new rectal cancer diagnosis are now younger than the age of 50 because it's more common now in a younger population, and the screening has recently changed that we now start screening at the age of 45, whereas in the past it was 50.
And I'm wearing my special button. If you are watching on YouTube, you can see that. It is just bringing awareness, like we have said, about screening earlier nowadays.
Yeah, and for people under the age of 50, colorectal cancer deaths have now surpassed lung cancer deaths, making it the leading cause of cancer deaths in men under the age of 50 and the second in women after breast cancer. And you're seeing a lot of this now in your practice.
We see a lot of colorectal cancer and a lot of very young patients with it. They tend to do very well when it's caught early, but again, catching it early is key.
Right. So it is the third leading cause of cancer-related deaths in people of all ages in the United States. So it's something that no matter what age you are, you really need to be aware of it.
Well, in the American Cancer Society, they have 5 signs of colorectal cancer that should not be ignored. So let's talk about those signs. 1, change in bowel habits. I mean, we like to do this. I've already mentioned on previous podcasts. We talk about poop, right? We have to look at it. We have to be pooping and be aware of what it looks like, because if you're constipated, having diarrhea, there's increased flatulence, which is gas, right? Or feeling that you cannot fully empty your bowels all the way. And even bowel incontinence, where you're just leaking. So this is critical. I mean, pooping cleans your gut out, but if there's a change in your bowels, we have to tell somebody. Tell your provider.
And blood in the stool. So typically they say that the brighter red the blood is, the lower down from the GI tract it's coming. And so, in your practice, you probably have a lot of patients who come in complaining of blood in their stool, right? And it's hard to determine, is this something you be worried about or something that you shouldn't be worried about?
Something that we definitely worry about. So we typically will ask patients not only if they have any bright red blood in their stool, but if they do, is it just only when they wipe it's more likely to be a hemorrhoid? Is it in the poop? Is it in the toilet bowl? And we also ask if they have any dark black stools, because sometimes that can be a sign of an upper GI bleed. Mm-hmm. And we always check their hemoglobin because patients who are anemic and having bleeding, we don't want to just assume it's from hemorrhoids or iron deficiency. So we typically will get them into a GI doctor fairly quickly for a screening colonoscopy and sometimes endoscopy as well.
Great. And then abdominal pain or pelvic pain or cramping. And sudden weight loss is never a good sign. I know everyone out there is trying to lose weight these days, but you got to do it the right way. And if it's just magically falling off, that's something that needs to be investigated.
Especially if it's unexplained weight loss. Now with everyone on Ozempic and Mounjaro, people are losing weight and having sudden weight loss. But if they're losing the weight and there's no good reason for it, it needs to be looked into. Prolonged fatigue. And like you said earlier, Blair, about the anemia, that can be from the anemia or it can be from the cancer itself.
Yes, very true. And we notice a big difference between patients who have a right-sided colon cancer versus a left-sided colon cancer. Sometimes the symptoms are a little bit different. So patients with a right-sided colon cancer, they tend to have more anemia, more fatigue. They'll often complain about blood in the stool. Patients with a left-sided colon cancer tend to complain about abdominal pain. Sometimes they'll go to the hospital thinking it's diverticulitis. and they're more likely to have some type of obstruction or something. So definitely very different symptoms.
Interesting.
And we tell our patients, be on top of your blood work. Have blood work done regularly because there's so many things you can catch in blood tests, not just the anemia. But I've caught a couple of cases of colon cancer in my practice because they have abnormal liver function testing. And when we pursue that, I mean, that's never a good sign because that sometimes tells us that the cancer has already spread to the liver. But I'm sure you see that as well, right? When someone comes in late in the later stages, that you have all sorts of blood abnormalities.
Yeah, and there is a test called CEA that can be a test for, it's a nonspecific tumor marker, but it's not recommended as a screening test because there's a lot of false positives with it, and it's, again, nonspecific. So if it comes back high, it could be from smoking, inflammation, and it doesn't point to any specific type of cancer. So we typically don't use that for screening, but in patients who are diagnosed, we do trend their CEA. Normal is 4 and under. So sometimes patients with metastatic colon cancer will have like a 300. And as they go through treatment, we trend it. And it's kind of a way for us to tell how well the treatment is working in between their scans because they only get scanned every so often.
Right.
And I'm glad you mentioned that it shouldn't be used for screening because I do have patients come to me who someone has told them or they read somewhere that you should get this test to see if you have cancer. And it's never a good idea because of the false positives. And I'm not just talking about the CEA, but there's
a lot of cancer
all of the tumor markers.
There's another one called CA19-9 that's specific for GI cancers, but again, not colon cancer. So we'll get a lot of requests for patients who come in, oh, my brother has colon cancer. Can you do this blood work? But again, those are about 80% accurate, and those being negative definitely doesn't preclude a patient from having colon cancer. So we still reiterate the colonoscopy is the best way to go.
Well, and who is it that should actually be screened? That's like the big question.
So anyone aged 45 and older, anyone with a family history of colon cancer, especially a first-degree relative, they really should get their first screening colonoscopy about 10 years before their relative was diagnosed. But we encourage primary care doctors to start asking about colon cancer screening and any symptoms at around age 20 because irritable bowel syndrome, Crohn's, colitis can increase your risk of having colon cancer. So there's a lot of young patients with it. So, when you're asking them when they're young, you're asking about their family history. Anyone who has a family history of anything, any genetic syndromes, like Lynch syndrome is one that we see a lot, and it's a very high risk of colon cancer or rectal cancer. So typically patients, if they have a family history of Lynch syndrome, will need yearly colonoscopies.
And there's also familial polyposis, is it correct? Okay.
Yep.
And that's where there's people, when they're very young, they have symptoms and they have tons of polyps, right?
Yep.
And that's genetic. Okay.
And so when new patients come in and we take a history, if they have a significant family history of patients, even if they're not first degree, say grandparents, cousins, aunts, uncles that had colon, rectal, esophageal, GI cancers, really all before the age of like 55, we'll tend to get a screening colonoscopy on them sooner. And we'll also order genetic testing to see if they do have any mutation.
Yeah, and I'm almost surprised when I take a family history at how many people have colon cancer in their family. I would think that breast or lung or prostate would be super prevalent, but actually most of the time, if they have a cancer history, I'm finding it's been colon.
Yeah, very common.
So what are the different types of screening methods? There's a lot out there. Some are better than others. Why don't you go ahead and fill us in?
So colonoscopy is kind of the holy grail of screening tests. A lot of patients really don't want a colonoscopy. They hear horror stories from their friends. The preps are definitely not as bad as they used to be. They're pretty well tolerated now. I think the hardest part is you can't really eat the day before. You have to have clear liquid. So patients don't like to take off of work for it. You're under anesthesia, so you're really not supposed to drive after. So we do get a lot of pushbacks with patients going for the colonoscopy. So a lot of patients will ask to do a test called Cologuard. And that's where the company mails it to their house and they do a stool sample. It's testing their DNA for hemoglobin and DNA mutations and methylations. It's more specific and sensitive than just a regular fecal occult blood test that you would do in the office. But the problem is if it comes back positive, the patients still need a colonoscopy regardless. So now you're kind of just delaying things. We also have a lot of patients that agree to do the Cologuard and they'll have it sitting at home for 6 months. So getting them to actually do it is sometimes a struggle and
I've encountered
things.
that. Yes. I'm like, just put it in your bathroom and just have it ready. Like read the directions so you know what to do when time comes. And there it is. It's simple. It's very simple to do.
And then it'll expire, and then we have to order it again.
Yep.
So we'd much rather just send them for a colonoscopy. The guidelines used to be that if you had a positive Cologuard or positive fecal occult blood test, you could repeat it, and if it was negative, you didn't have to follow up. They would assume that the first one was a false positive, but they found that that actually is not true. So if a patient has a positive fecal occult blood test or a positive Cologuard, insurance does cover a screening colonoscopy, and we do encourage them to get it within 3 months. Usually the sooner the better, because again, it's not normal to have blood in the stool. And, we do see a lot are benign that are hemorrhoids, but those are really the best screening tests. Some patients do ask us about a virtual colonoscopy, which, again, we don't encourage. It's for patients that are have a lot of comorbidities and are kind of higher risk going under anesthesia for a regular colonoscopy. But with the virtual colonoscopy, they still have to do the prep. So most think that with the virtual one, they're getting out of the prep, and that's why they'd rather do it. Once they hear they have to do the prep, they usually will change their mind pretty quick. And then we're exposing them to radiation and contrast. So, it involves their kidneys and everything.
Because it's a CAT scan, right? Mm-hmm. Ultimately.
There is a risk of perforation as well. And if they see, they're also doing a CAT scan, so they sometimes will pick up incidental findings that leads to additional testing and everything. And if there's anything abnormal, they need a regular colonoscopy anyway. So most patients, we have very few who have done the virtual. Most GI doctors will not do them now. And most who do get the virtual colonoscopy end up having a regular colonoscopy anyway. So it kind of just delays, if there's anything going on, definitely delays their treatment.
As we tell our patients also is once they're in there, if they see a polyp, they can just remove it in a colonoscopy. Yeah. But in a virtual, then now you're going for 2 preps, 2 procedures.
2 anesthesias.
And a lot of times the insurance companies haven't even been covering the virtual colonoscopies. So another test that... were you going to say something about?
Yeah. So another one I was going to say was the sigmoidoscopy.
Yeah, sigmoidoscopy.
Yeah. Say that again.
Sigmoidoscopy.
Okay. Yes. So that one only sees the lower third of the colon, which I've never been a big fan of those because if you're going, you still have to do the prep, and if you're going through all that, just get the whole colon, right? The whole large intestine, and so that's where you can see the entire thing. And what people need to understand is that a colonoscopy does not see the small intestine at all. So there you can still have issues in different places throughout the colon.
So for patients who do have a significant family history, when we send them for a screening colonoscopy, we'll usually recommend that they have a screening endoscopy as well. But that's a really good point because the endoscopy only does the esophagus and part of the stomach. The colonoscopy does the large intestine, but there's really no way to see the small intestine besides something called a capsule endoscopy,
right,
where they swallow a pill with a camera on it, but that's typically not used for screening. That's more if patients have a bleed that, they can't find where it's coming from and they're worried about arterial venous malformations. So it's definitely not, we do have patients ask about it, can I just swallow the camera? And they could look, but again, if they see anything, they still have to go in, and insurance typically will not cover it for a screening test.
And in your practice, I'm sure that small intestine cancers are pretty rare compared to colon cancer.
Yeah, right? We see a lot of AVMs in the small intestine and bleeds, but I can't think of many cancers that they found there.
So there's also, we talked a little bit about some stool-based tests. So there's currently 3 types of stool-based tests that are approved by the FDA for colon cancer screening. The first one is the guaiac fecal occult blood test. And that's where they use a chemical to detect hemoglobin in the stool. In the older days, doctors used to do a finger exam where they would put a finger in the rectum, and that's okay. I mean, sometimes you'll pick up rectal cancers by doing that, and then they used to put it on a fecal occult blood card and check to see if there's hemoglobin, but we found that those aren't so accurate, and we really don't do those very often anymore. Then there's the FIT test. Do you guys still recommend the FIT test, the immunochemical fecal occult blood test? That's where you mail the card to the lab.
We do not.
Well, to be honest, if it were up to me, I'd rather poop in a container and do the Cologuard than smear my own stool on 5 slots on a card and put that in the mail. And it's not as accurate.
Yeah. And then there's the multi-targeted stool DNA testing, which is called the FIT DNA, which is the Cologuard that we talked about. And we're fans of the Cologuard. We use it for screening. But here's my issue with colonoscopies is that the recommendations now for a normal colonoscopy are every 10 years. And we find that colon cancers can develop a lot faster than 10 years, right? I mean, even in 2 or 3 years. So our recommendation has been for people who are told to come back for a colonoscopy in 10 years, why not just do a Cologuard in the interim in 5 years? And that way you're really covering your bases.
Exactly. And the good thing about the Cologuard is there's no dietary restrictions, whereas when you were doing the other stool-based exams, I think you had to avoid like red meat and beets. And I feel like I remember learning that in PA school. I haven't used them personally in so long because I just don't think they're accurate. But I like not having any dietary restrictions.
And then people ask us about blood testing. And there are some blood tests for colon cancer, but we want to emphasize that these blood tests are meant to be complementary to and not a replacement for the current recommended colon screening guidelines. And one is Guardant Shield. And we actually did some of the clinical trials on that test in our office, and we had quite a few patients. I don't think we had a single one that ended up having colon cancer, so we can't tell you how accurate that one was, but that's available. And then there's the Gallery test, which we do make available to some of our patients, but you have some concerns about the Gallery test, right?
Yes, so it is something that we do offer to patients. We don't have many patients do it. It's not covered by insurance, but it does look for any circulating tumor cells in the DNA. Again, it's out of pocket. The biggest issue with it is it's checking for those circulating tumor cells at that moment in time. So at that moment in time, the patient may not have any tumor cells, but 2 days later, they may. And our concern is that patients take the test and it's negative and they think, I don't have to do my colonoscopy. I don't have to go for my mammogram. I don't have any cancers. It doesn't prevent them from getting any cancers. It doesn't tell them their likelihood of developing anything. It's just like a Polaroid snapshot in time. So I think it gives patients a lot of false guidance there.
Exactly. We always make sure we advise our patients of that. Just because it's negative today doesn't mean you can't have cancer tomorrow. And it goes hand in hand with another, we do cancer screening blood tests. There's many, many different companies out there, but we use a company called Natera, and they do a lot of, different genes that would put you at predisposed to cancer, and they do all that. And the reason I like doing those is I did have somebody that came up saying that this gene is linked with Lynch syndrome, actually. So it said they actually need to get their colonoscopy screening right then and there. So that helped us a lot. And without doing that test, we would have never known. They didn't have a family history.
We're huge fans of those tests.
Exactly. And and that can give you guidance on when to screen and how often to screen. And that goes hand in hand with multiple different cancers. But the one thing I also like to our audience to know, and why we're big fans of actually doing a colonoscopy, is when you see the colon, you're going through the colon with this camera, you can actually remove a polyp right then and there that can prevent it from turning into or a mass or cancer, precancer, whatnot. And even if those polyps are benign, then that is a determining factor on how often you should have your next colonoscopy.
And most cancers, not all, but most colorectal cancers do start out as polyps. The other problem with polyps also is they can get quite big and actually block the intestine. So it's a good idea that if there's polyps there, just to remove them. And then the guidelines change. In our area, most of the gastroenterologists are recommending that if you have a polyp, that you repeat the colonoscopy in 3 to 5 years.
Same.
So let's talk about some risk factors for colon cancer. Black ancestry. It's been shown that African Americans have a much higher incidence of colorectal cancer than in Caucasians or people of other races. And is that what you're seeing as well in your practice?
Hard to say. I think we would probably. I think it depends on the area of different office and different demographics. So I can't say that I've necessarily seen that, but I think in other parts of our practice, other offices probably do see it. Obesity is a huge risk factor, smoking, and we have a lot of patients that we see for iron deficiency due to Crohn's colitis. So we usually recommend they get screened earlier. They usually do have a pretty significant family history of autoimmune, and
I can imagine the inflammation is putting you at risk, right?
Also, and they're always having blood in the stool unless it's well controlled. So they tend to get frequent colonoscopies as well.
And diabetics are at risk for colon cancer, which a lot of the diabetics don't know. I mean, diabetes is a risk factor for almost everything. So pretty much we tell them that you're at risk for everything. So you need to be extra careful with your screening.
And on top of the obesity, and it doesn't even necessarily have to be a person of obese size, but a sedentary lifestyle, alcohol consumption, and a diet that is high in fat and low in fiber can all lead to a poor gut and colon cancer.
And if any of you have listened to our environmental toxin podcast that we did, you know that there's so many toxins in our environment and we're being blasted all the time. And I believe that that's one of the reasons why we're seeing such an increased rate of colon cancer these days. So that may be a good podcast to listen to hear about other things that you can eliminate from your life.
And the other biggest risk factor really is increasing in age. So ages 40 to 49 are the most common. But one thing I wanted to touch upon as far as screening goes also, the guidelines do say that patients can stop screening colonoscopies once they're 75 years, as long as they have a life expectancy greater than 10 years. But we don't really follow those guidelines because we have a lot of very, very young 87-year-old patients, 82-year-old patients that really have no comorbidities and they're very healthy and active. And we don't want to not screen them and be age cyst and not give them the chance to catch something where they would, qualify for treatment and potentially be curable.
I'm really glad you brought that topic up because same with us in our practice. We have people who are 87, 92, still playing golf or pickleball, and they're very healthy. And the thought of just saying, okay, well, you're done. We don't have to worry about this. Like that just does not fly with me. So that's an individual conversation I have with each patient, right?
Yeah. Guidelines are, in my opinion, guidelines are recommendations. And the same goes for mammograms. I mean, there's so many doctors who stop and say, nope, you reach this age, you don't need a mammogram anymore. Patients should have that choice. They should be able to decide if they're still going to have a colonoscopy or still going to have a mammogram.
Yeah, we'll have some patients come in with significant family history, breast cancer or colon cancer. And, well, I'm 76. My doctor told me I don't need it anymore. I'm like, but you're not on any other medication. You're healthy. Of course, we would want to still screen you because if it's caught early, it's curable. And
that's where the different type of screening tools come in hand because as we do get older, we do know that there may be an increased risk with perforation with a colonoscopy, right? But at least if we do a screening test, one of the other stool-based or blood tests, then we can determine if they ultimately need that colonoscopy. But we don't want to put them at risk for something that we have another alternative option. But that's, once again, an individualized treatment or screening plan that we have to discuss with the patients. And
since you brought up risk, everybody has heard a horror story from someone who's had a colonoscopy and something happened. They had a perforation, they had a reaction to the anesthesia. Yeah, it's going to happen, but the benefits still outweigh the risk. And those are rare. And I've seen maybe one or two in my entire career, and I've seen dozens of colon cancers detected during a colonoscopy. So I would say disregard what you hear because that's not you. It could happen, but it's not likely to happen.
Yeah, we send a lot of patients for colonoscopies. I've only ever had one patient have a perforation, and again, it's really rare. And I kind of wanted to go back when you were talking about the reasons why people don't do colonoscopies, and you were saying the prep and taking time off, and the prep can be brutal. Trust me. I mean, I get it, but at the same time, a recommendation I heard from a family friend a while ago, and I advise this on my patients is if you eat light for the 3 days before, 5 days before, and you're not eating burgers and steak because we know beef sits in the gut longer and takes long. It's a harder to digest food. But if you eat salads and soups and fish, or if you're eating light for that few days, then you don't have as much to clean out, basically. Technically, we should all be eating like that on a regular basis, but we don't. And so I have found that to be really helpful. And you don't get as much cramping during the prep and whatnot. And now there's also different preps out there. You don't have to drink the jug of Go Lightly.
Yeah, it's a much smaller amount. Yeah, it's a much smaller amount. And you can also, some doctors just use Miralax and they'll do a capful of that every hour. Some people pay to have the 2 pills and they're done. So there's a lot of different preps out there. So if you're not comfortable, talk to your physician about that or to your provider.
But you have to make sure you do the prep correctly.
You have to.
If you're not cleaned out, you're going to be going back and having another procedure.
Yeah, and
Exactly.
sometimes when patients refuse the colonoscopies and we ask why, and they say they had a horrible experience with the prep last time, we'll ask them what happened. A lot will say they had nausea, vomiting from it. And when you interrogate them a little further, they try to chug a gallon of this prep within 5 minutes. And
Right.
of course, anyone is going to not feel so well from that. So we'll encourage them to, just take very small sips and everything. And most of them do totally fine with the prep. It's pretty rare that patients actually get sick from the prep anymore these days.
Right. And how do you know if it's working? Well, you need to be pooping clear liquid by the time you are going for that colonoscopy. Otherwise, if you still have substance in there, you probably should just reschedule or call them immediately.
Right. So let's talk about some other factors that may play a role in the development of colon cancer. There's a substance we talked about in the past on this podcast called TMAO. TMAO is a toxin that's produced by certain bacteria that live in the intestine. And it's one of the tests that we use for heart disease as well, because TMAO has been implicated in both. And we're not sure why what the mechanism is of how it affects colon cancer, but we do know that it increases colon cancer risk. And if people have high TMAO levels, then we recommend that they stay away from meat, eggs, and full-fat dairy, like cheese and things like that. Then we talked about environmental toxins, right? There's several, BPAs.
Right. And phthalates and, just everyday toxins like pesticides. All of our food is practically contaminated, heavy metals. So we do a lot of that testing in our office to figure out how we can prevent complications down the line.
Yeah. And, of course, the diet that's high in red meat has been implicated anyway, even without the TMAO. And then we'll talk about treatment. So there's different treatments that are available for people, right?
Yep, a lot of treatment options now. Typically, so any cancer is staged, really stage 0 to stage 4, stage 4 being metastatic, meaning it's spread outside of the original organ into another organ. Typically, when it's stage 4, we tell patients it's not curable, but there are a lot of treatment options that patients can go into remission and have good quality of life and live for a pretty good amount of time with it. Typically, patients don't need chemotherapy unless they are stage 2B or higher. 2A is kind of controversial. A lot of times we'll discuss it with the surgeon and see if they had any invasion of the tumor into like lymphovascular invasion or neurovascular invasion. Make sure they took a good sampling of the lymph nodes. If there's any lymph nodes that are positive, that puts them at higher risk. And there's a lot of adjuvant therapies in addition to chemotherapy now. Something called VEGF inhibitors, immunotherapy. Not every patient is a candidate, but they're typically pretty well tolerated and they definitely increase the overall survival rate. We will typically do something called CARAS testing on any stage 4 metastatic colon cancer patient. Unfortunately, insurance doesn't cover it unless it's stage 4, but it would be helpful to have earlier. The CARAS testing looks at the molecular profiling of the actual tumor itself. So we tell patients it's almost like genetic testing in your blood, except it's not your blood, it's the tumor, because you can have acquired mutations. And the future of colorectal and really any cancer is the treatment is more targeted therapy. So sometimes we'll find patients that have a certain mutation and there's a pill that they can have in addition to chemotherapy or to eventually be on maintenance therapy specific for that mutation, and they do great on it. Sometimes we'll find mutations and there's, no specific treatment available, but they're constantly coming out with new things. And we have had patients that 2 years ago had this mutation and now there's a drug available and we can add it on and stuff. So
technology is insane. That's great.
A lot of treatment options, which is nice.
And does that mutation, you have that just in the EMR, or does it go into like a database?
It goes into a database.
That's awesome.
And we keep it in our EMR, and
great.
So it'll flag it if there's something available.
And is surgery the first line for almost every patient with colon cancer?
Depends where the tumor is and how big it is. Ideally, we want to do and how symptomatic the patient is. Ideally, they want to do the smallest surgery possible. So typically, if it's found on colonoscopy and it's, I'm not sure exactly what size the cutoff would be, and sometimes it's surgeon dependent, they would do a resection first, and then we typically wait at least 6 weeks. Ideally, you want to start at around the 6-week mark, chemotherapy. Radiation is never used for colon cancer, only for rectal cancer, because the different mucosa in the intestines. So the treatment for rectal cancer is probably a good amount tougher than colon cancer, because for rectal cancer, you're getting chemotherapy and radiation, and the radiation is tough, especially in that area.
Right. I'm sure that can cause like pain and inflammation, swelling.
Yeah. So if it's a very large tumor, sometimes we'll do neoadjuvant chemo to try and shrink it. And then they'll have surgery, and then we'll put them back on chemo.
Okay. So as in almost every topic we ever talk about on this podcast, our first line treatment is always going to be diet and lifestyle changes. And we recommend anyone with cancer, the first thing they do is clean up their diet significantly. We're big believers in going largely plant-based, limit your meat intake, limit your processed food intake, decrease your intake of seed oils.
Decrease alcohol, and definitely don't smoke.
Yeah. So it's been great having you on this podcast.
It's been great being able to join you. Thank you so much for having me.
Of course. Thank you for informing our patients and our audience.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem, or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions, or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.